what you're doing in there, and let's go to start. So last month here in Brazil, we had the Violet June. Okay, it is a big campaign here about the prevention and the information about Keratoconus. And the principal point that we need to say for our patients is that they cannot rub their eyes. Okay, this is the principal, the number one risk factor for developing and progressive of the Keratoconus. Okay. As a background, I'm gonna say some data of this disease. So it has a variable incidence. We can find in the literature some different numbers because of genetic factors. So in different populations, we can find different numbers, but in general, we can resume it for one case in 2,000, okay? The second point that is very important to bring here is that Keratoconus is the disease of young patients, okay? So when we have a young patient entering in the hospital, we need to bring in our minds what are the possible diagnoses that we can think. So young patients between 13 and 18 years old is the age when they starting developing the keratoconus. And another important point is that the progression after 40 years old is very hairy, okay? And it has an explanation, and then I'm gonna tell after, okay? But keep this in mind. Another point here is that it's a bilateral and asymmetric disease. So when we found a keratoconus in just one eye of the patient, we need to keep in mind that the other eye may have an corneal ectasia, subclinical corneal ectasia, okay? This is gonna be important for screening for refractive surgery, okay? So not all patients, we say, not all patients can do refractive surgery, but some of them, because some of them appear to have risk of developing ectasia, okay? Other point is the atopic profile or allergic conjunctivitis. We know that rubbing the eye is the major risk factor for developing the cone. And if we don't treat the allergic condition of the patient, we don't take the antigens from the environment of the patient, the patient will continue rubbing the eye and continue progressing the cone. As I said before, the genetic factor plays a role in the disease. So in 6 to 8% of the cases, we can see a genetic factor, okay? And we need to remember that the cornea is a collagen structure. So collagen disease, Ehlers-Danlos or Down syndrome has a prevalence, increased prevalence when compared with normal population. And why the Keratoconus patient rub the eye? Some patients have, as I said, this allergic or atopic profile, but we know that in the tear film of those patients, we have pro-inflammatory cytokines increased, okay? With those, these cytokines, they are increased. So that's a reason why those patients rubs their eyes, okay? And what is Keratoconus? Keratoconus belongs to the chapter, if we open a book, of the Corneal Ectasia disease. And the definition, by definition, an ectasic corneal disease or corneal ectasia is a group of progressive eye disorders characterized by thinning and protrusion of the cornea, resulting in moderate to severe impairment of vision. Okay, in this group we have the most prevalent is the keratoconus, but we have also the pellucid marginal degeneration, the keratoglobus, and the post-refractive surgery ectasia. Okay, we have also the posterior keratoconus, but it's not as prevalent as the keratoconus. Okay, and that is the main subject of this presentation. Before we talking about the keratoconus and the disease, the corneal disease, we need to remember the normal cornea, all right, the corneal anatomy. So just to bring back to the memory of you, we have 5 layers in the cornea. Okay, so the epithelium is the most is the first one. Under the epithelium we have the Bowman's layer, and under the Bowman's layer we have the stroma. The stroma represents 90% of the thickness of the cornea. Okay, and it's basically collagen fibers distributed with some extracellular matrix. Okay, and in the inner face of the cornea we have the endothelium, that is very important for the physiological maintaining of the transparency of the cornea. Okay, and we have the descendant membrane. Okay, so all these layers will be affected in this disease. Some points that we need to remember also are the average thickness of the cornea, that in median it has 550 microns. Okay, a normal cornea, and an average power, average dioptries of 43.5. Okay, remember these points because they're gonna be important. And how is the presentation of Keratoconus? Well, clinically, the young patients will come to visit us, saying that they are having a blurring or distorted vision, and they always complain about frequent change in their prescriptions. All right, so if we have an asymmetrical or an irregular astigmatism as Keratoconus, or a progressive worsening in the astigmatism, we will have this frequent change in this prescription, and the patient will not achieve 20/20 in their vision. Okay. Also, they complain about distorted night vision, because when we are in the low light ambient, all right, so when the patient is driving or in night vision, we have the pupil dilated and more distorted vision. All right, so the retina is exposed for optical aberrations from the periphery. Okay, so the worsening vision in the night is another symptom that they relate. Okay, remember that keratoconus also is a bilateral and asymmetrical disease, and high myopia and irregular astigmatism need to be highlighted for those patients. Also, they will present with eye rubbing and atopic or allergic profile. Okay, and in a small cases, in 3% of the cases, sometimes the patient can come to visit in the office with an acute corneal hydrops. Okay, this is an acute complication of the evolution of the keratoconus. And in this case, remember, if we have the keratoconus progressive, getting more advanced, sometimes the decimate layer, all right, remember here, this layer under the endothelium, this layer can suffer a break. And in this case, here, as documented in image B here, if we have this break in the endothelium and the decimate membrane, we will have influx of aqueous humor to the stroma of the cornea, and it will result in a corneal edema, in a blurry image. The patient will have photophobia and pain. Okay, and this is the these images below are the two examples. All right, this left one is a very huge corneal drops. Okay, and the right one here is a patient that I had in the office, and this is a small point. All right, this was a small break, resulting in the acute corneal drops, but the patient was very symptomatic. And the treatment in those cases, they usually have a complete resolution in 6 weeks. All right, but we treat them with hyperosmolar eye drops. All right, so if we have a corneal edema, we need to help the resolution of this edema with hyperosmolar eye drops and no steroidal anti-inflammatory eye drops and cycloplegics for the pain. All right, and if the patient don't respond for this initial treatment, or if he have a very huge corneal drops, sometimes we can do some surgical interventions for those cases. All right, it can be used so gas injection in the anterior chamber of the patient, or a full thickness corneal suture. All right, because the objective in this case is to promote the decimate membrane to reattachment to the corneal stroma. All right, and this will result in a more physiological way to the endothelium, promotes the restoration of the cornea. Okay, so the first one, the blurry vision and progressive blurry vision and eye rubbing, is the chronic and classical case. And sometimes we can have these acute corneal eye drops. All right, and the patient, when he's evaluated with our ophthalmologist equipment, we can see some signs of this corneal ectasia. Okay, the earlier sign that we can see is the alteration or abnormal reflex on the retinoscopy. We can have the scissor reflex or the oil droplet reflex. Those reflex are signs of irregular astigmatism. Okay, a classic sign is the Vogue strias, that are those thin white lines in the deep stroma of the patient, and this sign represents a tension in the collagen fibers. We can also see some prominent corneal nerves due to the thinning of the cornea. We can see flash ring. All right, this picture actually is a little difficult to see in this picture, but the flash ring is a subepithelial deposit of iron, okay, in the base of the cone. And in the more advanced case, we can see the Munson sign. All right, So as you posted today in the Instagram of the ophthalmology interest group, that is the Munson sign. All right, when the patient looks down, we can see the form of the Keratoconus in the lower lids. All right, this V format, is secondary from an advanced Keratoconus. And in the last one, we have the acute hydrops. So after we have the examination of the patient and the anamnesis, we will have to ask for some complementary diagnostic exams. One of them, and the most accessible and low cost, and the first exam that we're gonna ask for the patient, is a topography and a pachymetry. All right, the topography, as I'm gonna say in the next slide, will show the irregular astigmatism, and the pachymetry will show a thin cornea compared with the normal individuals. Okay, and I point here the tomography. The corneal tomography is also a very usable complementary exam, but in the Keratoconus, it will be reserved for intrastromal ring surgery, for the surgical planning, okay, for the position, the extent of the intrastromal ring, and it will also be very useful for screening of corneal ectasia in patients that are applying for refractive surgery. Or in resume, tomography will be very useful for early diagnosis, okay? But for the diagnosis of keratoconus, the topography is an excellent exam. Also, I point here some other exams that we can ask in the daily practical, like the Corvis. The Corvis ST is a new exam actually that it gives an analysis of the biomechanical properties of the cornea. Okay, the wavefront assess of low and high order optical aberration, and the OCT that will detail the corneal layers. Okay, so the corneal topography is an equipment based on the principle of the Placido rings. Okay, the Placido rings are projected in the front of the cornea, and these concentric rings will be interpreted by the equipment and will result in a color map. All right, so here we have a pretty anatomical cornea. All right, we can see the concentric rings, and here in the right we have a distorted rings. In this case, we have a corneal ectasia. All right, and this will be shown in those colorful maps. In this image, we have an example of keratoconus or a corneal ectasia, and we have those two images are actually the same image, but they have different steps graduation. So one of the first things that we need to look in those maps are the color grading. Okay, so in the left one we have a color grading that is separated by 0.5 dioptries. Okay, and in the right we have one that is separated and then graduated by 1 dioptries. So we have a more sensitive and more preeminent image here in the left one. Okay, but they are the same patient and the same eye. And a very classical study of Rabinowitz, you will heard about of this doctor in this class. A corneal study of him have described 10 patterns of corneal topography. Okay, and he found that the inferior steeping pattern, the symmetrical bow tie with skewed radial axis, the asymmetric bow tie with inferior steepening are the principal patterns that indicate a corneal ectasia. And the last one is a pattern that reunites these three patterns, is the asymmetrical bow tie with skewed radial axis. Okay, just to summarize, those criteria are described as increased area of corneal power surrounded by concentric areas of decreasing power, or an inferior superior power asymmetry, and a skewing of the steepest axial axis above and below the horizontal meridian. These three criteria were used initially to distinguish between anatomical corneas and ectasic corneas. And with those criteria, Rabinowitz had pointed some values for the diagnosis of Keratoconus. So a central curvature above 47.2 dioptries, or an inferior superior asymmetry above 1.4 dioptries, or asymmetry between eyes above 1 dioptry. Okay, in the steepest curvature, or the skewed radial axis above 22 degrees. Those were the initial values of the topography to diagnose a corneal ectasia or the Keratoconus. Okay, and based on those values, okay, we can classify the patient based on the K value of the steepest axis of the cornea. We can divide the patient in a mild keratoconus, in a moderated, or in advanced keratoconus. This is very important because when we will talk about visual rehabilitation, we need to have in mind that keratoconus is a very individually disease, and it will require an individual rehabilitation too. Okay. Further, Rabinowitz also have developed an index for diagnosis of keratoconus, but in our daily practice, we don't use it very much because it is actually a very complex, and it's only very sensitive and specific for more advanced cones. Okay, so early Keratoconus, they lost a lot of the sensitivity of this index. So in summary, this analysis of the cornea and those data, they are not be very sensitive when used for keratoconus suspect or very early keratoconus. And what was the next step? The advance in ophthalmology. For those patients is the corneal tomography. So different from the corneal topography that is Placido rings based. The corneal tomography is based on the shine plug based machine. So it can provide much more defined maps of the cornea. All right, so we also have the anterior, sagittal, and tangential curvature maps that is given by the topography, but the main achievement of this exam is the pachymetry map and the thickness profile, and the anterior or posterior elevation maps. Those two index that are highlighted here are very important for early diagnosis and corneal ectasia screening for patients that are applying for refractive surgery. They are also important, as I said before, for surgical planning of intrastromal rings, the location, the thickness, and for early diagnosis. Okay. This is an example of corneal tomography. So here, the first map is similar with the topography that we have here, the axial curvature map, but we have here a corneal pachymetry map that will show pachymetry, thinning profile of the cornea, and the posterior. And here below we have the anterior elevation and the posterior elevation. And this map is actually very important for the subclinical diagnosis. Okay, this is the first map that suffer an alteration on the keratoconus patient. The important thing in the corneal pachymetry map is to locate the thinnest point. All right. So in corneal ectasia, we will have a dislocation from the anatomic thinnest location. It's usually located in the apex of the cornea, and when we have the corneal ectasia, this will be dislocated far below the center of the cornea. Okay, as this example. And here on the right is a demonstration of how we look and how we read the posterior elevation map. So we look to the 6 millimeters circle. All right. So we look to all those values, and we look for the most negative value and the most positive value. All right. So the gap between those two values will give us a suspect of corneal ectasia. In this example, we have the gap between those two values is 30. All right. So when we found a value above 27, we can suspect of corneal ectasia. And this image here below is an example of how posterior elevation of the cornea is more sensitive than the anterior surface of the cornea. All right. The treatment of those patients will follow two principles. The first objective is the progression of the progression control, and the second point is the visual rehabilitation. All right. So the most important is avoid eye rubbing, as said before, and we need to talk and explain the patient about the importance of this. Also, we can talk to the patient if he have a lot of discomfort in the eye. He can use cold compress that will help with the stimulus, and we need to treat them pharmacologically with antihistaminics and mastocyte membrane modulators, as example, Patanol and Octifen. Okay. Also, we need to remember to treat systemic treatment of those patients that suffer from allergic pathologies or atopic. And the last one is the cross-linking. The cross-linking is a very important procedure, and I'm gonna talk in the next slide. Okay. So if the patient is already under the treatment with pharmacological eye drops, and he say that he's not rubbing his eyes anymore, and if we have documented the evidence of progression, that is a cerometry K value increased in 1 dioptry in 12 months, or a ceratometry K value increased in 0.75 in 6 months, okay? Increase in myopia by 0.75 spheric under cycloplasia in 12 months, or the decrease in 2 lines in best corrective vision in 1 year, okay? Those are the formal evidence of progression, okay? And what is the cross-linking? The cross-linking is a method to stabilize the corneal ectasia progression. Remember that the cornea, the corneal stroma is mainly formed with collagen fibers, okay? And the Keratoconus patient, they have an altered biomechanical, all right, of the cornea. So we have a weak cornea, and that is suffering the protrusion, the ectasia over the time. So the cross-linking, what we do, we take off the epithelium of the cornea, and we use a photoinductor. In this case, is a riboflavin, and with ultraviolet irradiation of this cornea, we can promote the cross-linking, okay? The cross-linking with the collagen fibers. And this linking will result in a more stabilized cornea and more strong ligations with the collagen fibers, okay? And this method of treatment is very useful, and we have a lot of stabilization of those patients, all right? We use the standard or the Dresden protocol. This is formally, we have 3 millivolts of energy per centimeter square for 30 minutes of irradiation of ultraviolet light in the cornea. But nowadays, we have advanced in the studies, and now we have the fast crosslink, all right? This is not the standard protocol, but nowadays we have some evidence that they are also useful, and we can reduce the time by increasing the power of the ultraviolet irradiation of the cornea, all right? So if we increase the power to 9 milliwatts per centimeter square, we can reduce the time from 30 minutes to 10 minutes, because in the calculation, the both patients or the both protocols will have the same amount of energy of 5.4 joules per centimeters square, okay? And those patients also, we need to remember that the Keratoconus patient will have a thinner cornea, all right? So in patients that have a pachymetry lower than 400 micros, we need to select an hyposmolar riboflavin, all right? This hyposmolar riboflavin will increase corneal thickness by 25%, by a osmolar effect. All right, so by and transitory edema of the cornea, we will have thickness increased, and this will be a protected factor for the endothelium, for it don't be harmed during this process. All right. So this is still stabilization of the cone. This we always have to say to the patients, because sometimes they come to the office and they ask about if they can do a cross-linking because they want to have a better vision. But we need to remember that the cross-linking is not a refractive treatment, but it's a progression control treatment. All right. And on the other hand, we need to remember the possibilities for visual rehab of those patients. So we need to go from a less complex to a more complex treatment. All right. And the classification of the patient will be very useful for trying a visual rehab. Okay. So the first one, and the very initial case, we can try glasses. All right. But it will not give the patient a 20/20 vision in the most of cases, because we have an irregular astigmatism, and the glasses will not be able for this visual rehab. Okay. The next step, we have the rigid contact lenses, and in more advanced cases we have the scleral lenses or the stromal ring. All right. The scleral lenses is a very interesting form of vision correction, because it can be very useful for very advanced cases. Okay. But it has its limitation. One of them is the price that is increased for the patient, and it requires a learning curve. It's more difficult for patient for getting used to. All right. And the stromal ring, as I'm gonna say in the next slides. In the last step of the treatment, and for the advanced case, we will have the corneal transplant. We have the lamelar transplant, that is the DALK, that is the abbreviation of deep anterior lamellar keratoplasty. And in the more advanced case, or when we can't do a lamellar transplant, we will use the penetration keratoplasty. Okay. Those cases will be very useful. And the contact lenses, we need to remember that the surface of the cornea will be individually deformed. All right. So every patient will present with a different pattern of corneal ectasia. We have the nipple for morphology of Keratoconus. We have the oval, or we can have the global Keratoconus. All right. So for each one, we will have to try any specific contact lenses design that will have a good accommodation to the cornea. This form of visual rehab is an excellent. It's a very good, because it's not an invasive procedure. All right. It's not don't require surgery, and the patient usually get excellent visual outcomes. We can correct the optical aberrations of the patient with this method. And the only thing is that the patient needs to be very well informed of the maintenance and the hygiene methods to conserve the lenses. All right. So sometimes when the patient don't follow the hygiene protocols for the lenses, we can have infectious keratitis, and sometimes those patients can evolve to corneal ulcers. Okay. Here are some examples of the rigid contact lenses. So in the right here, we have the normal rigid gas permeable contact lenses. And for the more advanced cases, we have this bigger one that is the scleral lenses for very advanced cases. All right. And below here, we have an example of how we study the adaptation of and rigid lenses to the cornea. We used a fluorescein eye drop that will stain the lacrimal film, and we can see if the corneal and the contact lenses are well adapted. Okay. So the next step is the intrastromal rings. This is a very interesting form for treatment the patients. We can use it for moderate cases or when the patient can't adapt himself with the contact lenses. Okay, this is a next step because this is more invasive. All right. But this procedure is reversible. If the patient is going under intrastromal ring and the results are not good, we can remove the ring and the patient will have the this will be reversible. Okay. And what is the effect of the intrastromal ring? All right. The stromal ring will induce the flattening effect. So the protrusion of the cornea will be flattening, and we will have a better vision outcome and a correction of the irregular astigmatism. All right. But the bad thing, the one thing that we need to learn is that we have unpredictable results. All right. So different from a refractive surgery that we can calculate the final prescription of the patient, as I can see, we have unpredictable results. All right. So every patient will react in a very individually form. All right. So this surgery demands a lot of surgeon experience for the planning, the position, and choosing the right ring for the patient. And for the advanced cases, we will have the corneal transplants. We have the penetrant transplant. Oh, this is the more invasive transplant because we will take the whole cornea and transplant for the patient. So as we have all corneal layers transplanted, we have a risk of endothelial rejection, and we have a durability of 20 years in 85% of the transplants for Keratoconus. So if we have a young patient and he have like 20 years old, this patient certainly will, and he goes under a penetrant keratoplasty. This patient, when he have his 40 years, all right, or 35, 40 years, he will need to be under a new keratoplasty, all right, because it has a durability of the cornea. The visual outcomes are good for the penetrant keratoplasty, and the mean best corrected visual acuity is of 2030 after 12 months, okay? And we have the advantage of, when compared with the lamellar transplant, is that the penetrant keratoplasty has a shorter learning curve when compared with the lamellar. All right, so it's easier to perform, and it can be performed by manual dissection of the cornea, or femtosecond laser assisted for personal designed of the borders of the transplant. And we have the lamellar keratoplasty. All right, the DOC, as we say, is the deep anterior lamellar keratoplasty. This transplant will just take the anterior surface of the cornea. This will take the epithelium until the deep anterior stroma of the patient, of the donor, all right? And the patient will receive this partial thickness graft, as it is designed here below, all right? So here in the first picture, we have the full thickness graft, and in the second one, we have the partial thickness graft, the DOC, okay? This is an excellent procedure and an excellent surgery because it is a less invasive. All right, it preserves the endothelial layer of the patient, so we don't have that risk of endothelial rejection. And another advantage of this technique is that it do not penetrate the anterior chamber, so we have less risks of endophthalmitis and expulsive hemorrhage that are sometimes seen in the penetration keratoplasty. Okay, and so in theory, if the patient receive this lamellar transplant, he can stay for the rest of his life with this new cornea. Okay, so different from the penetrated keratoplasty that has a time. All right, so in 20 years he will need to be under a surgery again. In this case, in the lamellar, in theory, he will not be he will not need a new surgery. Okay, but the disadvantage is that it's a very difficult to do. The surgeon needs to have a lot of experience, and it requires a long learning curve when compared with the other technique. And another thing is that during the preparing of the patient, sometimes during the dissection, the cornea can be violated, and the lamellar transplant need to be converted to a penetrant transplant. All right, we can use the manual dissection technique, or the big bubble, that is also a manual form for corneal dissection, or we can use the femtosecond laser to perform the dissection of the cornea. So in summary, the main message is that you need to take from the Keratoconus, this presentation, is that we need to remember that the Keratoconus is a bilateral and asymmetrical disease. We need to stay in alert for young patients with high astigmatism or insufficient visual acuity correction with glasses. We need to inform and prevent the ocular rubbing with information and treatment of allergic conditions, and using eye drops for the patients. We need to follow up those patients for evidence of progression. Every 6 months is is a good time for follow-up. And we need to choose the best visual rehab for each specific case, all right? So we need to remember that it's an irregular astigmatism. We have corneal ectasia. So as it is an individually disease, we will require an individually treatment, okay? Here, just to finish this presentation, I bring to you a very interesting image that I found. Is that those two images here above are the topography of Mars, all right? Those maps are I found in the NASA web page, and they look just like the Keratoconus as we see now, all right? So we have inferior steeping here, as seen the tomography. We have here in the surface of the Mars, and in the elevation map, we also have the elevation curvature, and it's also seen here in the topography of Mars. So I need to bring this for you because I found it very, very nice, and now you're gonna see the maps in a different way, I hope. All right.
Very interesting. Thank you for the lecture, Doctor. It's an honor to have you. I hope everyone enjoyed it. If anyone has any question, this is the time to ask them.
Yes, and if anyone want to send a message or something, we can find me on Instagram. All right, and I hope that I could help you and your group with this class.
Does anyone have any question for the Dr. Santana?
Yes, I have a question. I don't know if I understand well or not. If a patient have keratoconus, they can have refractive surgery or not?
No, they cannot. All right. So I'm gonna come back here in the
Any level.
what? Let me show you here. Just let me share again the screen. All right. So you can see my screen here.
Yes, we can.
Okay. So when a patient applies for refractive surgery, okay, one of the most fears of the ophthalmologist is that the patient can evolve a corneal ectasia after the procedure, okay? So as I said before, the topography exam is just good to see developed keratoconus, all right? But we cannot see early cases or ectasic corneas. So when we see those patterns here, all right, in a topography, when the patient asks for a refractive surgery, we do a topography, and if we see suspicious pattern, all right, as an inferior steepening or something, or a asymmetrical bow tie, we need to investigate if it's a ectasic cornea or not. And those patients with those topography patterns, we will ask corneal tomography, and we will see the corneal pachymetry and the posterior elevation. Those maps will show early keratoconus or ectasic corneas, and those patients cannot be operated for refractive surgery. Okay.
Okay, thank you so much.
another question or? All right. So again, I'd like to thank you, Valentina, for the invitation. And have a good night, everyone. Thank you.
Good night, doctor. Hope we can have another one in the future. Thank you, everyone, for
Yeah,
attending today.
of course. If you need, just send me a message and we keep in touch, okay?
Okay, bye, everybody. Good night.
Bye-bye.
Thank you, doctor. Good night.